So I'm not here to talk specifically about child and adolescent obesity. Boyd, just to let you know, there's a separate paediatric meeting happening in this Congress at this very moment. So the people who do know about growth charts are probably in another room. I've been asked to talk about the healthcare system, and so I've tried in general to not be too paediatric in my approach. I wanted to start, you can probably work out how I answered the app. Obesity is a serious, chronic, relapsing disease. It's common. I have the data for both children and adults, as well as New Zealand and Australia here, and as we noted before, it is somewhat more prevalent in New Zealand than in Australia. It is more prevalent in adults than children and young people, but it's very prevalent. Clearly, prevention is vital. I'm not going to talk about that today, but effective management in the healthcare system of those people who are already affected is also vital, and that's a really important aspect of what we need to do as physicians. However, I'm here to say that our healthcare systems generally fail people affected by obesity. Now, I want to just highlight a few issues around this. I can't cover this whole topic in the time I have, but I want to start by saying that people with obesity present frequently to the health system, but aren't necessarily offered treatment. So I want to start by showing some data for the wonderful Beach data set, which was an annual national random survey of GPs, so 1,000 GPs, surgeries were randomly sampled, and 100 consecutive patients had the data was collected on those. For the 4 years of when we looked at this, we looked at 4 years of data for people aged 2 to 17 years, and we had 40,000 patients who were looked at, and it was self-reported height and weight, so that tends to be an underrepresentation of overweight status. And we also looked at what treatment they were being offered. So of every 200 children presenting to their GP, 30% had overweight or obesity, and 23 had obesity itself, so 11.5%. So that's higher than the background prevalence in the community as far as we know. And guess what? One was offered any form of treatment, whatever way we could work it out in terms of weight management. Now that was in general practice, and it was to do with children and young people. But I'm here to say the situation is very, very similar in secondary and tertiary care. So we have done these studies in Australia looking at secondary and tertiary care. It's also the same with adults, and it's also the same in other countries. People with obesity are already presenting very frequently to clinical services, no doubt in large part because of comorbidities associated with their obesity. But their underlying problem, what is often their underlying problem, or this morbid problem there, is usually not being treated primarily. Now, let's also look at another issue that you encounter in the healthcare system. Weight bias is a problem. So I want you to go to the app, and we have this question about weight bias. Just on the other question, you can answer the second question as well while you're at it. So I want you to think of a health facility or an institution where you work or with which you are familiar. So if you're not working clinically with people, you can think about another hospital or healthcare system. How much does weight bias influence the access to and quality of clinical care received by people with obesity? Do you think it's an issue? You may not know, or you may think it's only a little, or you may think it's quite a lot. So just reflect on that and fill in that question. And we might ask the AV people to actually show us the response to this question. So a lot of you didn't know, most of you didn't answer. A moderate amount, quite a bit. Well, maybe this is why I'm here to talk. So if we could go back to the slides, please. So I want to give some examples of weight bias, possibly at a hospital near to you. So this is a story of Brian, aged 12 years. He has severe obesity and long-standing hip hip pathology actually secondary to his previous septic arthritis. He's in a crowded outpatients clinic at an adult hospital. The doctor, who's due to see him, sees him and calls out across a crowded waiting room, "You're as big as an elephant." And the mother, who was recounting the story, said, "Everyone turned and looked at him. His eyes welled up with tears." Or think about this situation. A physician was receiving more referrals to manage patients affected by severe obesity in the hospital outpatients clinic. A senior hospital executive noted the increased referrals and met with the physician, literally saying, this person told me this, "These patients don't need to be seen here. There are more important problems to be managed in our outpatients clinics." Or what does this extract from a hospital's manual handling policy say about the experience of being weighed if you are a large person? Section 14, weighing. Patients up to 150 kilograms can be weighed in ward. Patients greater than 150 kilograms will need to be weighed using the hospital loading dock. The linen room loading dock weigh machine is the best option, preferred time after 1 p.m. We'll need to test if the bed can be weighed on this particular hospital's loading dock. If not possible, need to go to the loading docks at the neighbouring hospital. Great experience, isn't it? So I'm here to say that weight bias amongst health professionals, the health system is alive and well, and it influences health outcomes. So there's strong evidence that healthcare professionals of all sorts endorse stereotypes, the community stereotypes about people with obesity, and that weight bias contributes to maladaptive eating behaviours among people with obesity. And there's moderate evidence that patients with obesity perceive biased treatment in the healthcare system, whichever healthcare system they're in, and weight bias increases vulnerability to depression, lower self-esteem and poor body image, and that people with obesity avoid healthcare facilities due to the bias they've experienced in the past, and that weight bias contributes to avoidance of physical activity and less engagement in weight control attempts. So there's a vicious cycle that gets caught up. It's actually very prevalent. These data do not just come from the USA, they come from many OECD countries, including Australia. And it's weight bias, or attempts to deal with weight bias, can actually be handled in a range of ways. So having appropriate chairs that can fit large people, having large gowns that allow dignity in being treated in a hospital, bathrooms that can really support a big person going to the toilet or having a shower, signage that doesn't say obesity clinic this way, but have other ways of being able to direct people where to go. These can help minimise weight bias. Okay, my next comment or point I want to make is that there's limited availability of bariatric surgery procedures in Australian public hospitals, and this may be an example, I believe, of institutionalised weight bias. We can talk about that issue again. Brendan Murphy actually talked about this issue about limited availability before, and he and I were both using the Australian Bariatric Surgery Registry, which is a voluntary registry by surgeons of patients having bariatric surgery in Australia, and as far as I understand it, tends to overrepresent the public hospital data, and is only just starting to get a large amount of the private surgery data in. So basically, there's a low percentage overall of bariatric surgery procedures in public hospitals, so 13 to 15%, if you can happen to see it. So down the bottom, 13% of primary procedures are done in the public hospital system. This is over about a 4 and a bit year period, and 15% of revisions. And if you go to the last 6 months of the Bariatric Surgery Registry, which is when they were getting more of, even more of the private surgery data, you're down to about 10% and 9%. Now reflect on this, given that obesity is much more common in people of low income and social disadvantage, and that private health insurance is much less likely to be had by those people. It seems that we're not getting those people and providing services for them. If you look at these data in another way, people patients in public hospitals having bariatric surgery have much higher BMIs, body mass indices, than they at the time of surgery or when they're being booked in, than those people who are met in the private system. So the BMI of people having surgery is about, in the private system, about 43 or 42 at day of surgery. Everyone always loses a bit of weight prior to surgery. That's part of importance in terms of shrinking abdominal fat, liver fat down. And in the public system, about a 5 to 6 unit increase, 49 down to about 47 BMI. And guess what? They're much more likely to have type 2 diabetes as well. So 28% in the public system versus 13% in the private system. You've got to really earn your bariatric surgery in the public system. Many more hurdles to get through. And there are multiple other barriers to effective service provision for people affected by obesity. When we asked family doctors, GPs, what they say are the barriers to primary care management, and I might say we've also looked at paediatricians from this point of view, issues come up of lack of time, lack of easy reimbursement, lack of patient or parent motivation, a lack of effective interventions or perceived lack of effective interventions, a lack of support services. Where do I send my patients to? Where can I get extra help? A lack of healthcare pathways, which is also part of that. It's a complex, difficult problem. It's highly sensitive, and guess what? I feel I've had inadequate training in this issue. So this is where I want you to go to the next question and fill in the question about how competent do you feel in raising the issue of obesity with a patient or a paediatric patient's carer, and in providing at least initial management and advice. You know, not at all competent, somewhat quiet or very. Because you may well be in the same league as most of the other GPs or the paediatricians that we've looked at in the past in this area. So could I, when you're ready, could we ask somewhat competent? And the next group, quite competent, and only a few of you, and some of you feel very competent. I put that down too. I thought I better, because that's my day job. And actually it's really great to see that maybe we've got a self-selected group of people here who are intensely interested in this issue. Tremendous. Doesn't mean we can't all do with more training though. We go back to the slides, please. So these are just some examples of how the health system seems to be failing people affected by obesity. I haven't touched on numerous issues which you may well want to raise in questions. I want to just now in the last few slides think about how we might deal with thinking about responding to this. I think of the healthcare system needing to respond to obesity in the bit of the way of our chronic disease care pyramid. We're familiar with this in terms of type 2 diabetes and chronic heart disease. So you have the underpinning of primary prevention and health promotion, very important. And then we need to have then the people with different levels and grades of severity of illness. For those with level 1 obesity, which is the vast majority of people, they can be managed in community settings, often with self-care, with support from group programs, other primary care GPs. And in fact, we've got good evidence from the Lancet around that just recently. Some people need to be provided care in specialist allied health or in group programs. A few need level 3 care with complex patients and key caseworker case managing, and of course we need linked bariatric surgery. Question to ask you, all parts of this pyramid are needed. What services are available in your region, and with whom do your services link? I've got some I'm briefly going to go through our personal recommendations. We really need to develop, evaluate and provide health professional training. The college needs to provide and require training positions. As far as I know, the only paediatric advanced training position in obesity is my one at my hospital, but we need other forms of training E-learning modules, we've got this one about to go live in New South Wales in the next week or so for paediatric care. It's going to be freely available throughout the country. Master's level training, we need a whole range of things, a huge role for the college here. We need to think about getting better data about how obesity influences health service use and costs in order to advocate for shifts in resources and reorganising of existing services. And maybe we can talk about what that might mean for things like cardiac disease, management of fatty liver disease, OSA, diabetes, arthritis, and so on. And we certainly need to have better ways of capturing height and weight routinely. And we clearly need to develop healthcare pathways locally to better enable us to be able to provide care, joined up care at primary, secondary, tertiary and quaternary level. So, my last slide, can we contemplate a near future when health professional students and practitioners are trained in the management of obesity, when people affected by obesity do not experience weight bias, where there are clear healthcare pathways for the recognition, assessment and management of people with obesity, and where our health services are reorganised to provide equitable access to high quality, dignified treatment. So as we reflect on that and think about the questions, I'll just leave you with the acknowledgements of a huge range of people with whom I interact in many ways, including people who love acronyms for our studies, and say thank you.